The human body is not a machine to be upgraded, repaired, or replaced at will. It is a complex network of systems, each part communicating with countless others, adapting continuously to the challenges of daily life. When we consider removing or altering an organ or tissue, it is easy to focus on the immediate promise, relief, convenience, or the appearance of improvement. Yet beneath the surface, every structure serves multiple roles, some obvious, others subtle, many still poorly understood. The liver filters toxins, regulates metabolism, and contributes to hormonal balance in ways that extend far beyond simple digestion. The thyroid orchestrates energy use throughout the body, influencing mood, cardiovascular function, and neurological processes. Even tissues that seem redundant or non-essential often have compensatory roles or participate in feedback loops that maintain equilibrium. When surgery removes or radically alters these components, the body loses more than just the targeted structure. It loses the resilience, redundancy, and nuanced adaptability that evolution has built into every system. This is why procedures done for convenience rather than absolute medical necessity carry risks that extend well beyond the operating room. People often assume that modern medicine can replace what is removed with medications, implants, or synthetic alternatives, yet these interventions can only partially replicate nature's sophistication. They do not recreate the feedback loops, regenerative abilities, or subtle signaling networks that the original tissue provided. Over time, this absence can manifest as metabolic imbalance, chronic fatigue, unexpected susceptibility to stress, or secondary health issues that appear years later. These effects are rarely part of the initial consultation because they require a perspective that stretches beyond immediate symptom relief. Even surgeries that are framed as simple or low risk carry this hidden dimension. The human body is designed with redundancy and adaptation. When a component is removed permanently, the system must compensate, sometimes overburdening other organs or pathways, creating vulnerabilities that were never present before. This is why reversibility demands more than consent. It demands deep understanding, reflection, and patience. It calls for asking whether the benefit today truly outweighs the lifetime of consequence tomorrow. It encourages patients and practitioners alike to consider alternatives, to explore observation, lifestyle modifications, or non-invasive interventions before choosing a path that cannot be retraced. The permanence of surgery transforms every cut into a dialogue about risk, reward, and long-term harmony with the body's natural design. In medicine, wisdom is not measured by the number of procedures performed, but by the discernment to know when restraint is more powerful than action. Irreversibility reminds us that every surgical decision echoes into the future, influencing not only immediate recovery, but the ongoing story of health, function, and well-being, a story written in living tissue that cannot be restored once altered. Respecting this truth is not fear, it is the careful listening, the pause, and understanding that every permanent change to the body carries a responsibility far beyond the operating room.
Surgery driven by imaging findings rather than the lived experience of the patient is one of the subtler pitfalls in modern medicine. Advanced scans, MRIs, and X-rays provide remarkable detail, revealing abnormalities that are invisible to the naked eye, yet the body does not always respond to images in the way we expect. A scan may highlight a disc protrusion, a minor joint degeneration, or a cyst, and the temptation to intervene surgically can feel compelling, as though correcting the image alone will resolve discomfort or prevent future problems. Yet the human body is not a static blueprint. It adapts continuously, compensating for changes, distributing load, and managing small imperfections in ways that imaging cannot capture. A visible anomaly does not always equate to pain, dysfunction, or risk. Many patients with striking scans remain entirely asymptomatic for years, while others with minimal radiographic findings experience significant discomfort. Surgery performed solely on the basis of imaging disregards the nuanced reality of adaptation and compensation. Every structural alteration carries consequences, and when the body has been functioning despite an anomaly, sudden intervention can destabilize carefully balanced systems. Muscles, connective tissue, nerves, and even the mind itself have adapted to the presence of that condition, creating patterns that maintain stability. Removing or altering tissue based purely on what is seen in a scan can destabilize these patterns, producing new pain, weakness, or secondary complications. It is a reminder that medicine must not lose sight of the living patient behind the data, the person whose daily life, activity patterns, and individual resilience inform whether a procedure is truly necessary. Listening to the body, understanding symptoms in context, and considering non-invasive approaches first are acts of profound respect for biological intelligence. Imaging is an extraordinary tool, but it is not destiny. When surgery is chosen without integrating patient experience, holistic assessment, and long-term perspective, we risk prioritizing the image over the individual, addressing what looks wrong rather than what truly matters. The body's adaptations often contain information about resilience, compensation, and potential recovery pathways that cannot be replicated once tissue is altered. Recognizing this encourages a more cautious, reflective approach, where surgery becomes the final option, not the first. True medical insight balances technological capability with human complexity, appreciating that the living organism may respond to stress, degeneration, or minor anomalies without direct intervention. The decision to operate should emerge from dialogue, observation, and thoughtful assessment, not merely from the apparent severity of an image. In this way, respecting the gap between what we see and how the body functions preserves health, minimizes unnecessary risk, and aligns medical action with the subtle intelligence inherent in the human organism, ensuring that intervention enhances rather than disrupts the delicate equilibrium that supports long-term well-being. Interventions that permanently alter anatomy to manage conditions rooted in lifestyle, metabolism, or reversible physiological stress are among the most complex and often overlooked decisions in medicine. The human body is designed to adapt to a wide variety of challenges, compensating for imbalances, stresses, and changes in ways that are subtle yet profoundly effective. When surgery is proposed as a shortcut to resolve a problem that is, at its core, modifiable through behavior, nutrition, movement, or hormonal balance, it interrupts this natural adaptability. Consider procedures that remove, reshape, or bypass tissue to address pain, weight, or digestive concerns. These interventions may provide rapid relief, but they also bypass the body's intrinsic capacity to self-regulate, creating a reliance on permanent structural changes rather than harnessing the physiological systems that originally caused the imbalance. Metabolism, hormonal feedback loops, and musculoskeletal coordination are highly interconnected. Altering anatomy can change how these systems communicate, sometimes producing unintended consequences that appear months or years later. The body often compensates in ways that are invisible until they manifest as new symptoms, inefficiencies, or vulnerabilities. Surgery, when chosen prematurely, can convert a temporary or reversible imbalance into a permanent state, making future correction more difficult and increasing dependence on medical management. Understanding the root cause of dysfunction requires patience, observation, and often subtle adjustments rather than immediate intervention. It involves recognizing that pain, inflammation, or structural change is frequently a messenger rather than a permanent enemy, signaling areas where the body is asking for support or correction rather than elimination.
Choosing surgical alteration as a first line of treatment can silence these signals, but also removes the opportunity for the body to adapt and strengthen naturally. In this context, restraint becomes a form of wisdom, acknowledging that the body's internal intelligence often surpasses our desire for quick fixes. Long-term outcomes depend not solely on the technical success of the procedure, but on how well the intervention aligns with the body's dynamic systems. Permanent anatomical changes should be considered only after all reversible or modifiable factors have been addressed, ensuring that the benefits outweigh not just immediate discomfort, but decades of future adaptation. The decision to intervene surgically must therefore account for metabolic resilience, lifestyle factors, and the potential for non-invasive recovery pathways. Recognizing that the body has evolved to compensate for imbalances encourages a measured approach, one that respects both the power and fragility of physiological systems. Surgery should never be viewed as a replacement for patient responsibility or biological understanding, but as a carefully weighed tool that interacts with an organism designed to heal, adapt, and restore balance on its own whenever possible. In this light, permanent interventions are not failures or errors, they are profound commitments that require foresight, humility, and deep awareness of the body's capacity for self-regulation.
Elective surgeries sold with certainty but supported by weak long-term evidence are among the most quietly troubling decisions in medicine. In these cases, the promise is immediate: relief from pain, improved function, or enhanced appearance, and the procedure may appear straightforward and low risk. Yet what patients rarely see are the long-term data, or the absence thereof, that reveal how often outcomes fail to meet expectations. The human body is remarkably resilient, capable of adapting to structural changes, pain, and even minor injuries over time. When surgery is chosen primarily based on anecdote, marketing, or the allure of certainty rather than robust evidence, it risks undermining the very systems it is meant to support. Every intervention carries hidden consequences: altered biomechanics, compensatory stress on surrounding tissues, nerve sensitivity, and hormonal shifts that evolve slowly, sometimes surfacing years later. The initial relief can mask these subtler, long-term effects, creating a false sense of resolution. Patients may wake up weeks after surgery thinking the problem is solved, only to discover that new limitations, unexpected pain, or dependency on additional treatments have replaced the original issue. This is particularly true when long-term follow-up studies are scarce or inconclusive, yet the procedure is promoted as definitive. Surgical certainty in the absence of evidence is a seductive illusion, appealing to both patients' desire for control and practitioners' confidence in technology. Yet biology does not conform neatly to human expectations. Structures interact, tissues adapt, and compensation occurs in ways that can never be fully predicted. When we intervene without understanding these long-term consequences, we risk substituting one problem for another, sometimes more complex challenge. True medical wisdom acknowledges the limits of our knowledge, recognizing that not all procedures with apparent short-term benefit are justified when weighed against decades of potential impact. It requires humility, patience, and a willingness to explore less invasive or reversible strategies before committing to permanent alteration. Elective surgery should not be an impulsive response to discomfort, fear, or marketing, but a carefully considered choice informed by longitudinal outcomes, patient values, and the intrinsic adaptability of the body. When evidence is weak, restraint becomes a form of protection, preserving the body's natural capacity to compensate, adapt, and heal. The decision to proceed must honor not only immediate symptoms, but the trajectory of health, function, and well-being over the years that follow. Every scalpel cut, every removed tissue, carries implications that may not emerge until long after the operating room lights are dimmed.
Recognizing the limits of certainty ensures that intervention is chosen thoughtfully rather than hastily, aligning action with biology rather than hope, and respecting the patient as a living, adaptive system whose resilience is often underestimated but profoundly consequential for long-term health. Every scalpel cut carries a promise and a price. In medicine, surgery is often portrayed as decisive, heroic, and final, but the human body is not a machine with replaceable parts. It is a living system shaped by adaptation, memory, and consequence. After years of studying anatomy, physiology, and outcomes, I've come to a quiet but firm realization. There are certain surgeries that look helpful on paper, sound convincing in consultation rooms, and yet too often leave people wishing they had paused, questioned, or waited. Not because surgery is evil, but because biology is unforgiving when we interfere without deep respect for long-term balance. Surgeries that remove organs or tissues primarily for convenience rather than clear medical necessity, especially when those organs play subtle hormonal, immune, or structural roles that medicine still doesn't fully replicate. Procedures that promise pain relief by cutting or destroying nerves, ignoring that pain is often a messenger of dysfunction rather than the disease itself. Surgeries driven by imaging findings rather than symptoms, where scans look dramatic, but the human being in front of the doctor is still functioning, adapting, and compensating. Interventions that permanently alter anatomy to manage conditions rooted in lifestyle, metabolic imbalance, or reversible physiological stress. Elective surgeries sold with certainty but supported by weak long-term evidence, especially when regret rates rise years after the operating room lights are turned off.